Thank you, sir. Thank you, Neeta, Sanjay, and Neglur, sir, for having me here. Now, to the audience, how many of you all actually have problems with extreme high doses of insulin? Fantastic. So it's relevant today. So insulin doses are increasing. Obesity seems to be the problem. Most importantly, 35% of patients with type 2 diabetes require a high basal insulin to start off itself, 60 units or more. In a treat to target basal insulin trial, almost 1/5 of them required more than 80 units of basal insulin. These are insulin naive patients. So requirement for insulin, the concerns with higher doses of insulin has been the weight gain, the hypoglycemia, the regimen complexity, and the cost. And what do we call as insulin resistance? In a practical clinical aspect, is patients who require more than 1 unit per kilogram are insulin resistant, and those who require more than 2 units per kilogram have severe insulin resistance. As a thumb rule, if you require more than 200 units of insulin, it's commonly considered as severe insulin resistance. And a large total daily dose can cause a lot of practical problems because we have a U100 insulin, and it can be very painful to sometimes administer if you have to administer probably a half or a 1 ml to each patient. So you have inherited and acquired insulin resistance. We look at the acquired ones, which could be inactivity, overeating, aging, medications, which Dr. Arvind Gupta spoke about. When we evaluate patients who have high doses of insulin, we need to see whether they have any kind of severe insulin resistance syndromes, or whether they are on medications that Dr. Gupta said could be antipsychotics, glucocorticoids, some oral contraceptives also cause. Any kind of secondary causes like probably an endocrine disorder, an acromegaly or thyrotoxicosis, which has gone unnoticed, may increase the insulin requirement. Again, physiological stress, pregnancy, puberty are the usual causes that we see in our clinics. Again, the therapy for insulin resistance, we have non-pharmacological and pharmacological. I'm just going to touch base on each of them. Exercise, we all know, is essential to reduce insulin resistance. Walking, swimming, cycling, whatever, but 150 minutes of moderate intensive activity per week would help in reducing the insulin resistance. Weight loss, easier said than done, but insulin resistance may improve with weight reduction. So in a lot of patients who are extremely obese and have high dosage requirement, when they undergo any kind of bariatric or gastric sleeve surgery, we see a lot of reduction in their insulin requirements. Diet, again, a low carbohydrate diet. Magnesium reduces insulin resistance. Vitamin D, zinc, and chromium have been shown to kind of reduce some amount of insulin resistance. Sleep deprivation again leads to insulin resistance, and the glucose homeostasis kind of completely gets tweaked when there is sleep deprivation, resulting in kind of a hepatic insulin resistance and kind of increasing the hepatic glucose output. So a good sleeping pattern is essential. Apart from that, smoking cessation in a small trial has also shown that it can reduce the insulin resistance. One of the most common drugs that we use for reducing insulin resistance is metformin. The home study actually randomized almost 400 patients of type 2 diabetes who were on basal bolus to 850 milligrams of metformin 3 times a day versus placebo. And what they found is that these patients were on almost 70 units of insulin, and the A1C was 7.8 to start off. And you had a reduction of 0.9% at the end of 16 weeks, with the p-value being significant, and the total dose did come down by approximately 10%. Metformin is the most widely used kind of drug to kind of reduce the kind of insulin dosage in patients with type 2 diabetes. Now we know that we can extend the use of metformin at a much lower dosage to an eGFR up to 30. Pioglitazone it was one of the drugs which, when came into market, had a lot of fan following because it was a true insulin sensitizer. This is a drug which was used earlier. There have not been a lot of studies on how reducing insulin resistance with TZDs, but this is one study which looked at kind of the safety and efficacy of adding pioglitazone on the background of metformin versus placebo in patients who have high insulin requirements. And at 20 weeks, both the groups experienced a reduction of HbA1c, which was almost similar, and the difference was not statistically significant. The mean dose with the pioglitazone group was a little bit lesser, but obviously the weight gain was higher. The weight gain was almost close to what we expect with concentrated insulin, and that's probably the reason that pioglitazone or any kind of TZD should not be used with insulin, and especially if you have to reduce the insulin requirement, because fluid retention, weight gain, probably fluid retention, and then leading to heart failure. GLP-1 analog, especially now when we have a GLP-1 and a basal insulin, one pen, can be used to reduce insulin requirement, because the problems of weight gain can be offset with the GLP-1 analog, which can help in weight loss and also reduce the insulin requirements. There have been some studies on liraglutide in patients who have needed very high dosages of insulin. And in a study of 37 patients with type 2 diabetes who required 200 units per day, addition of 1.8 milligram of liraglutide resulted in 35% insulin reduction at 6 months. And another study where patients required approximately 100 units of insulin per day, addition of liraglutide resulted in an 18% overall reduction of insulin. So GLP-1 is a very good, effective strategy in reducing insulin requirement in patients who have very high insulin resistance. This is a study where the effect of liraglutide was used in patients who actually required a concentrated insulin, which is U500 insulin, and it was a safety and efficacy study of liraglutide in patients who required U500 insulin. Approximately 18 patients were studied, and at the end of the study, there was a 1.4% reduction in HbA1c. There was a 5 kilogram drop in weight, and the requirements also came down. So patients who require very high dosage of insulin, GLP-1 is a good strategy kind of to reduce the insulin requirements. SGLT2, we just spoke about SGLT2 and euglycemic diabetic ketoacidosis, but in practice also, if you have to reduce insulin requirements in patients with type 2 diabetes, SGLT2 is a very good drug. Probably there are a lot of studies which have said that probably 10 to 15% of the total dose of insulin may come down by addition of an SGLT2, but you need to realize that insulinopenic, and we should not be reducing our insulin initially itself. Probably you may end up with euglycemic diabetic ketoacidosis. This is a study of empagliflozin where it's the 25 and the 10 mg of empagliflozin is compared to placebo in patients who required higher insulin dosages, and the reduction in HbA1c is close to 0.4%, but in clinical practice we do see much better reduction in overall insulin dosage. So available data on SGLT2 that it's when combined with insulin may lead to modest improvement in glycemic control and modest weight loss. None of the other therapies have a lot of role in reducing insulin requirements. Concentrated insulin is what we would need when patients require higher dosage of insulin, because it's not always possible to satisfy the dose requirement based on what we have today. So we all know what is concentrated insulin. You have more amount of more units of insulin in a smaller volume. Just to tell you that the PK/PD of concentrated insulin, degludec, lispro, and regular insulin remains unchanged, but we know that glargine, it changes. But U500 regular insulin, there's a PK/PD change. It more or like behaves like an NPH insulin rather than a prandial insulin. So when we start, we don't have U500 here, but if we ever get it, it would be more like a premixed human insulin, or probably like an NPH insulin, where patients may be required only to inject twice a day or maximum to thrice a day. So human regular insulin is approved in 1994. U500 is available in vials. In July 2016, the FDA approved the first dedicated U500 syringe. Now it's available also in the quick pens. It's not yet available in India. I'm not going into how you would kind of tweak the dosage of U500. When it comes into availability, we'll speak about it. So U500 would hold approximately 1,500 units of insulin per pen. If you look at the syringe also, it's got a green cap, and it's marked till 500. Humalog 200 is another insulin which is available in India. That's lispro at a concentration of 200 units per ml, and this can be used to kind of reduce the insulin requirement or probably give a lesser volume for the same dosage. So in a nutshell, I would say that U500 insulin, when it comes into India, would be the kind of game changer when we require higher dosages of insulin. Till then, GLP-1 RAs and metformin seems to be the best bet to kind of reduce the insulin requirement in patients who require very high insulin requirement. So in conclusion, the absence of any true contraindications, metformin should be the first drug to be added. Weight gain is a problem, so probably GLP-1 RAs come in. SGLT2 also have a favorable effect and can be considered. Thank you so much.